Today we're going to kind of spend some time talking about medications that help to modulate your immune system with a specific focus on vaccines. In order to have this discussion, the first thing we need to do is we need to kind of go over a little bit of your immune system. The immune system, guys, it can be a little complicated. Going over this every time you hit an immune section in your further studies will really kind of help to kind of put it into your brain. Let's get going. First and foremost, here's a breakdown of our learning outcomes for this time. And then let's talk about our immune system. So the first part of your immune system that we want to talk about is your innate immune system. This is kind of like the first line of protection. These are the guys that are on first lookout all the time. If they see something that shouldn't be there, they're immediately going to start to pour out, and they're going to find what it is, and they're going to engulf it, kind of like a piece of Play-Doh going around something. The problem with these guys is that they're not very specific. They don't actually remember what they did, so it doesn't matter. They're like, oh, there's a bad guy. Oh, there's a bad guy. And so it just eats everything in the immune system. So great guys to have on our team, but we do need something a little bit more adaptive, a little more targeted to what some of the pathogens that may or may not be in our body. This is called the adaptive body defense system. So it works in tangent with the innate. So the innate is like, okay, let's go to work now. And the adaptive is a little bit more strategic in what it does for your body. It does identify specific threats. It primarily uses the big old lymphocyte to go in and to reach around and grab the bad bugs. And what this adaptive body system does is it uses its lymphocytes, it reaches over and it grabs the bad guy, and then it takes the bad guy and it very strategically moves to the lymph sites. When it gets to the lymph nodes, one of the things it does there, it begins to activate other body systems. It says, hey, look, this is the bad guy that I caught. I need you to remember it. And so it finds B cells and T cells in the lymphoid tissue. And then the lymphoid tissue, the B cells and the T cells, start studying the enemy. They study him frontwards and backwards. And they figure out what mechanisms they need in order to attack this guy right now, and they develop these tools in order to be able to do that. So the lymphocytes are very, this adaptive body system is very important in order for us, whenever we hit this organism the next time, it remembers it. So with this adaptive body system, we have this humoral response. So your B cells, so that the lymphocytes, okay, they grab the bad guy, they take the bad guy to the lymph nodes and says, this is the bad guy. Then the B cell comes over, okay, we'll make this is the B cell, okay. Okay, the B cell comes over and he studies everything about the bad guy, right? He's studying, and he's going to make some tools. Then he's going to turn, and then there may be a T cell involved, okay? And the T cell comes up, and he comes and he looks at the bad guy and he figures it out. So the T cell is kind of like a quick guy because he's kind of tall and skinny and he runs around really fast. And he says, okay, I got it. And he runs out first and he starts attacking whatever this bad guy was. But the B cell continues to study it and study it and study it and looks at it very, very carefully because he wants to know everything about it. So that if this bad guy ever shows up again, he'll have the correct defense system in order to be able to attack it and squish it and get him out of the body, okay? Because he likes things to go really well. So that's kind of what those they do. The B cell actually helps us to produce antibodies. He's kind of like the roaming police. He roams around the body, he sees if there's something there, and he marks them for destruction. The memory B cells take time to make, and so it may take it may take up to 10 days to make enough antibodies to go out and fight the bad guy. But over time, this gets better because the B cell remembers, and then the next time that same antigen or pathogen shows up in the body, the humoral response system says, I know who you are, I know why you're here, and guess what? I already have everything in here to fight you. And so it actually will produce an immune system 2 times or 3 times as fast because it knows what this bad guy is and knows how to defeat them. So again, I was telling you about the B cells and the T cells. They hang out in the lymph node system. The T cells really help us to combine our different types of immunity. It helps us to take this adaptive and our adaptive immunity and our innate immunity, and it kind of brings the two together. It's kind of like, okay, everyone work in conjunction. It's kind of like an orchestrator. The helper T cell guy is really important whenever we begin to talk about HIV, because typically HIV, whenever it gets to the body, it affects our helper T cells. So when I talk to students about helper T cells, I always tell them, like, they're part of the lookout system that is constantly looking for bad guys in the system. And it can form some memory cells about the different antigens that it sees. But the problem is that eventually HIV can take over these T cells, and this is what causes their immune cellular failure. Part of the helper T cells makes part of the cytotoxic T cells. These are kind of like the body's assassins. They kind of go around and they're like, oh, ta-da! And they're like ninjas. And they keep things in check. They keep bacteria in check. They keep parasites in check. They even keep cancer cells in check. I tell people that our CD8 cells are a lot like suppressor cells too, because one of the other functions that our cytotoxic or our CD8 cells have is that they keep our good bacteria and our bad bacteria in check. So they know that there's a medium between, like, say, E. coli in your abdomen that's supposed to be there. Well, the CD8 cells kind of help keep everything in balance, okay? Not too much, not too little, just in balance, kind of like a bouncer, okay? In balance. But again, when we talk about HIV, we'll talk about how these receptors are also affected. So just thinking about the immune system, like I said, it can be a little complicated. There's a lot of guys out there that are working to help to make sure that you stay healthy. We use all this information to help us to mitigate some really nasty diseases by causing the cells to remember the nasty diseases so that they know that they can't affect our body like they want to. With the activation of our immune system, we can kind of got it boiled down to two different types of immunity. We have active immunity and we have a passive immunity. So active immunity is what happens whenever I'm physically exposed to something. So as a child, I grew up in an era where we didn't have varicella vaccines. So I actually had contracted the disease chickenpox. Okay, so I have that in my body. Therefore, I have antibodies running through my body right now. They're detectable that says that, hey, I've had this pathogen before. Now, I can't get chickenpox again because that pathogen has antibodies in my system. The other type of immunity we have is called passive immunity. And this is when it's transferred or donated from one person to another. So whenever I think about passive immunity, I think about moms and babies. As a mama who was pregnant, all the antibodies that I had in mine, when that baby was born, there was a certain amount of those antibodies that were passed to my children. We can also provide passive immunity when we, if say that someone gets exposed to a disease, but they've never been vaccinated for it, we can give them antibodies that will help to protect them from getting the disease. So let me give you an example. So active immunity is I've either had the disease or I've got a vaccine. Passive immunity is from person to person, and it can even be whenever antibodies are transferred. So I had a young lady that came in, and her family did not believe in vaccines. So the baby had had no vaccines at all, and she was 7 years old. The day prior, the child was running through the barn and was wearing a pair of flip-flops. And when she was running through the barn, the rusty nail went through her foot. Okay, so completely through. Dad grabbed the hammer, pulled the nail out, and then they brought the child to the doctor the next day. The mother was concerned that the child was going to develop tetanus. So what we did is we gave the child tetanus antibodies in order to prevent the disease from occurring. Okay, so that's how we gave that patient passive immunity. We couldn't give her active immunity. We couldn't give her the injection and just hope for the best. Instead, we had to give her the antibodies, which would help to protect her against the disease for now, and then we would give her a vaccine later to have her active immunity started. So again, we use all this type of information, this active and passive and B cells and T cells and how the immune system works in order to be able to produce, manufacture, and to give vaccines to patients to prevent diseases that could cause long-term illness, disability, or death. So with our vaccines, the kind of the drive home points that I want to get to you is that the vaccines help our immune system, specifically our B cells, to form the memories, the antibodies that are necessary in order to prevent you from contracting that disease if you were exposed to it. Now, I will tell you, as we age, sometimes we don't have the levels of antibodies in our systems that we need in order to be able to prevent that disease. So there's something called a titer. A titer tells us exactly how many antibodies you have in your body. And then based upon studies, we know that when a titer gets to a lower level or this level, that you no longer have active immunity and you would need a booster of that medication. Because ultimately, our long-term goal would be that we give you one shot and you're done. But we're finding out over the years that our immunity to certain diseases, the titers that we can run on people, are actually lower. This actually caused a change within the last 5 years to the way that we give vaccines. One of the medications called tetanus. So what would happen is when you turn 5 years old, you would get your last tetanus, diphtheria, and pertussis injection. And then after that, when you turn 10, we would just give you a straight tetanus injection. What we found is that the tetanus, diphtheria, pertussis, as you age, you don't have an increased risk of the disease. However, we found that you were a carrier of the disease. It was up inside your nasal passages. So we had a lot of adults who hadn't had tetanus, diphtheria, pertussis injections since they were children, who were now carriers of the disease, and would get like a mild cold or something really kind of, innate, not harmful at all, but they would pass that disease to small children, to infants. So what we decided, what the CDC, the Centers for Disease Control, has decided to do is that whenever anyone gets their tetanus booster updated now, instead of it just being a straight tetanus, it's tetanus diphtheria. Because what we found out was that tetanus diphtheria, it was diphtheria that was in your nose, that was what was being passed on. So now whenever you get an update on your immunizations after you turn 10, it is typically at least one time in your lifetime you're getting a booster on tetanus, diphtheria, and pertussis so that you're no longer a carrier and you're not passing it to other people. Okay, so that was kind of one of the things that we found. With vaccines, and this is something that I think that you need to put into your brain, is that we have a couple of different types of vaccines. We have live vaccines and we have inactivated or dead vaccines. When we say live vaccine, we really mean attenuated, okay? And that's a fancy word for we basically took the disease and we put it into a test tube system, and then we beat it all up and we punched it in his head, and it's just kind of sitting there like, it's not really fully functional, okay? We attenuate, we bumped it on its head and we made it a little bit stupid, okay? When we give patients live vaccines, if they have a compromised immune system and their immune system can't look at this and go, oh, you're measles, and I should do something to you, and I should blah, 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 and activate appropriately, what we'll find is that these patients may have a subclinical appearance of the disease itself. We see this frequently whenever we give children the measles vaccine for the first time. Typically what happens within 24 to 72 hours, there is a group of children, we can't predict which ones and which not, but they will develop a light, mild rash and a mild fever after receiving the measles vaccine, okay? We see this a lot whenever we give patients the influenza vaccine. People will say, well, I got the flu shot and I got the flu. You didn't get the full flu, baby. You got the partial flu, okay? Just a little bit of a kicker as your immune system. You got a little bit of the flu. If you had gotten the full flu, you'd been down for days on days and felt horrible. I can tell you a great example of this last year. As a nurse practitioner, I was seeing patients in their homes, and those patients who had the flu vaccine, those kids were up running around, being their normal kid self. Now they had a fever and maybe a cough, but they were totally fine. They were up and they were just running around. They had a fever, but they were okay. The ones who did not have the flu vaccine, these were the kids that were like laying in mom's bed, not moving, not eating, getting the really, really high fevers and looking like they felt really, really poor. So even though the flu vaccine, they received the flu vaccine, or I'm sorry, that when they didn't get the flu vaccine, they still could get the flu, but it wasn't near as bad as those children who did not receive the flu vaccine. Okay, again, the flu vaccine comes in 2 flavors. It comes in a live version and an inactivated version. So with an inactivated or a killed vaccine, basically what we do is we take heat or chemicals and we destroy any signs of the active disease in the vaccine. So it really can't replicate or cause disease, but it means that your immunity is not going to last for as long as it would had you received a live vaccine. Again, we have the influenza virus is both influenza vaccine is both in an attenuated version and an inactivated version, so you can see it both ways. Again, these vaccine types are what we use in order to be able to make some medication decisions. If a patient has an immunocompromised state, then we don't want to give them live vaccines unless it's discussed, risk benefits, the whole 9 yards. There are just some medications that those patients shouldn't receive if, say, if they have cancer or a severely weakened immune system. When we talk about vaccine types, we have both the toxoid ones. These are the ones that are chemically modified to be incapable of causing a disease. And then we also have the recombinant ones. These are the ones that we actually make in the lab. And the example of that one is like a hepatitis B vaccine. That's actually a recombinant one that we've made in the lab. Common side effects for all vaccines: redness, discomfort at the site of injection, minor aches, arthralgias, fever, not feeling well for a couple of days. You got to remember that when we give a patient a vaccine, that we're asking their body to make immunity, okay? So that's a big, huge deal. It's not like the body can just be like, okay, yeah, sure, I'm going to do that for you right now. No, it can take days or weeks. So with this, when we give vaccines, especially to children, or even my yearly flu vaccine, when I get my yearly flu vaccine, I tend to get it on a Wednesday, which is my last clinical day. And then I would plan on being like, I don't want to say laid up, that's not a good word, but I would take really good care of myself for the next 3 to 5 days. Plenty of fluids, lots of water. If I needed to take a nap, I took a nap. If I was achy, I take some Tylenol. Take good care of myself because my body is building up immunity. I want it to have everything it needs in order to make those antibodies so that I don't get the flu this year. There is always the potential that whenever we give a patient any kind of medicine, that anaphylaxis can happen. Anaphylaxis is a severe allergic reaction in which the child will develop trouble breathing, maybe nausea. Well, I say child, but any of us, trouble breathing, nausea, vomiting, hives. These can all happen when we give any medication, but for vaccines, because we're giving them IM, it's probably a little more susceptible, okay? So one of the things I always want to encourage you, if you're the person administering the vaccine, is that you tell those people you have to wait a minimum of 15 minutes before you're able to leave, okay? Typically an anaphylactic reaction will happen within the first 15 minutes. It can happen longer than that, but if we hold those patients for 15 to 20 minutes after any injection, we're probably 90% clear that they won't go home and have a future reaction. Sometimes whenever babies get their MMRs, like I said, they'll develop this little rash all over their bodies and they'll have a fever, and you'll get a lot of panicky phone calls from moms. Oh my gosh, they have this rash all over their body, they're having a reaction. No, mom, this is a good sign. This means that their body is working really hard to make antibodies. So why don't you keep that baby at home, keep them comfortable, and we'll see you in a day or so and see if it doesn't get better. Okay, so always helping to reassure. If the mom is panicking and they want to be seen right away, I tell them to come on back in, or we'll say, bring them up here, let's look at them. And typically that's what it is. It's a rash following the MMR vaccine. It's pretty notorious. Just this year, there was a new opinion that came out from the American Academy of Pediatrics in regards to pre-medicating children for vaccinations with Tylenol or Motrin. It has kind of been the habit and the practice for the last several years that whenever children are fixing to get ready to have their vaccines, that mom or dad will go ahead and give them a little Tylenol before they come to the office, or just be prepared to give it to them because of the achiness. The American Academy of Pediatrics is now saying, maybe that's not the best practice we've ever had. I will tell you from a parenting perspective, if that child is uncomfortable and grouchy and running a fever, and I can give them Tylenol and that's going to make them feel better, then that as a mom is what I'm going to choose to do. So I don't know how many of the pediatricians have had children that they've had to do this with yet. I feel like if they had children and they had to put up with the grouchies after vaccinations, that they may have a different opinion. But they say that they don't know if it's any of a therapeutic, more of a therapeutic benefit. Okay. Immunocompromised patients, patients who have HIV, patients who are pregnant, patients who have cancer, patients who have leukemias, any kind of a weird bone disease, they have special schedules printed for them by the Centers for Disease Control. These patient schedules, we always want to talk to a physician about them before we as nurses administer any vaccines. Because their immune system may or may not be where it needs to be, giving them a live vaccine may be harmful for them versus an attenuated. Okay. If a patient has diarrhea, vomiting, or fever, or pregnant, again, usually we're contraindicating any kind of vaccines, especially with the diarrhea, vomiting, and the fever. Those patients, their immune system's already pretty active because it's fighting off something already. So to ask the immune system to do more, you may overwhelm it. With pregnancy, most vaccines are category C. I will tell you that we do administer with every pregnancy a tetanus, diphtheria, pertussis, Texas and diphtheria booster. And the reason we do that is because that immunity from mom is then transferred to the baby and offers them a more protection. So I know that some of you probably are like, okay, wait a minute. So typically I get a tetanus vaccine once every 10 years or every 5 years if I have a cut, scratch, or scratch, right? But if I'm a pregnant mom and I get pregnant today, and in 9 months from today I deliver, and then I'm lucky enough to get pregnant again within the month, and I'm pregnant the next year too, then we will give you another tetanus booster with that pregnancy so that you can pass those antibodies on to your fetus. So with every single pregnancy, moms are now getting a tetanus, diphtheria, pertussis, tetanus and diphtheria booster. With nursing, one of the things that we do is that we are very instrumental in helping and encouraging the public to get vaccinated. We are the ones who help to remind patients that vaccines are important. There was legislation that came out a couple of years ago that requires us now all to get a flu vaccine, or else you have to document proof and then you have to wear a mask. I'll tell you, I don't see very many masks being worn in the facilities that I'm in. Almost everyone takes some form of the influenza vaccine. Patients, especially our elderly, are most at risk from dying from the influenza virus or the pneumococcal disease, one of the pneumococcal diseases, one of the pneumonias. So with these patients, it's very important that we help to ask them every single time we see them, and especially when it's in season, did you get your flu vaccine this year? You know, it's not too late. A lot of our hospital facilities, when they're inpatient, we're offering these vaccines free of charge. So, and very important for them to get their medications. Our high-risk patients, our pregnant patients, diabetic patients, renal failure, COPD, asthma, HIV, patients with cancer, those all patients are all considered high risk. And because they're so incredibly high risk, we want to make sure that they're getting their yearly immunizations as well. So checking with them, making sure that they've got them and that they can document the time when they had them is extremely important to help to keeping them healthy. Here's a couple of extra resources. I want to let you know that there is an app for that. There is an app that you can download to your phone, absolutely free, from the Centers for Disease Control. And that little back, it looks just like this. It says CDC on it. You can add it to your phone. And what's really cool about that, it gives you all the vaccine schedules. Excuse me, child, adolescent, adult conditions, adult ones, and even contraindications. So that way when you're in clinical and you have any questions or someone asks you about a vaccine, you can say, hang on, there's an app for that. I also gave you a additional resource here for osmosis. Osmosis is a free online resource that talks all about pathophysiology. They go a little deep, okay? They go a little deep on the explanation because typically osmosis is more for physicians and providers, but they give a lot of great graphics, It's free. I like free. I like Osmosis and I like the Khan Academy. Both of those are free resources for you guys so that you can make sure that you know what's going on with your with the pathophysiology behind what we're talking about. And then finally, here's a little reminder for all of those pregnant patients that they will be getting a Tdap, which is the tetanus, diphtheria, or cellulitis pertussis vaccine, which is always recommended for those patients between the 27th and 36th week. They're getting another tetanus shot. Ouch! And again, it's to help to protect their babies. All right, guys, this is all about vaccines, and we will talk to you guys later.